And this reminds me that actually in '95, this is 21 years ago, we organized a conference on condom supply for the Baltic countries here in Vilnius, exactly in this hotel. It's so a historic coming back to this place. I could continue reminding you that prevention of nosocomial infection is one of our main tasks. And if my colleague spoke of dedication, which is necessary, and of monitoring of quality measures we can undertake in the hospital setting, that is very much important. If a patient comes to our institution for hip replacement and then he dies with a pneumonia from a multi-drug resistant germ, we have not done any beneficial for him. So this also ethically is really a challenge for us to get control of these things. And I would like to share with you a couple of thoughts. In my talk, we look on multi-drug resistant bacteria. We have the methicillin-resistant Staphylococcus aureus. We have the Clostridium difficile associated diarrhoeum, which also can develop very unhappily toxin, which can spread also in the hospital setting. We have the extended spectrum beta-lactamase enterobacteria, like the coli, like the Klebsiella, and other gram-negative bacteria. And we have the vancomycin-resistant enterococci. They are in focus besides other germs. If you look to the geographic map of the world, then you see that we in the Baltic Sea region, and I'm also living at the Baltic Sea in Mecklenburg, Pomerania, close to the Polish border. We are sharing the same sea water. And we are in a happy part of the world where this magnitude of resistance is still low. If we look to the maps of the European CDC in Stockholm, and we see this for Klebsiella pneumonia isolates on the left part of the map, we see that in the Mediterranean, in the southern countries like in Italy, especially in Greece and also in Romania, we have an increasing proportion of carbapenemase resistant Klebsiella. The right pattern of countries shows you the resistance to Staphylococcus aureus, which are also with a north-south gradient. Imagine that by now, more or less, most of the countries face that a quarter of all their isolates of Staphylococcus aureus already are resistant against methicillin or oxacillin. And this has, of course, a lot to do with antibiotic consumptions in the countries. For Germany, you see a map on regional antibiotic prescription density, and that means that more or less more than 1% of the entire population, 1% of all inhabitants, from baby to very old people, are permanently under antibiotic treatment. And this gives the bacteria the chance to develop resistance. There is no necessarily correlation between infectious diseases and antibiotic consumption. Therefore, I show you this geographic map, and you can easily see that the former GDR are significantly lower in consumption and prescriptions of antibiotic. We have the same epidemiology of all kind of bacterial infectious diseases which ought to be treated by that. There is no reason, so it has to do with the behavior of the patients. In many countries we still have no law that we have to get a prescription. You can buy them in the drugstore, on the pharmacy without physician's prescription. And with the behavior of the prescribing physician, who very often, for instance in a phase of influenza, still are prescribing antibiotic. Sometimes also on false request by the patient and by being shy to have the discussion, which is necessary to convince the patients that with a viral flu he should go without an antibiotic prescription. What is happening in the hospitals? We are now forced to monitoring our antibiotic drug prescription density on the way that we have to indicate how many daily doses of the drug are prescribed on 100 patient days. And you see smaller hospitals have half their patients on a daily basis under antibiotic treatment, and university clinics are 70% of all patients' days are covered by antibiotic. So the hospital setting surely is one to pay attention that we are producing antibiotic resistance in our hospital settings. But we are in one world. It is not only the hospitals. By far the majority in humans are prescribed by GPs and by internal doctors in the ambulatory sector. And the double amount which is applied to humans, at least this applies for Germany, is given to pigs, cattle, to poultry, to the industrial production of food. And we know that this circle of creating resistance has been established. 1.5 years ago, the German federal government for the first time issued a report to the parliament on resistance of bacteria against antibiotics for the first time. So in this report, which actually were written by the Robert Koch Institute, the federal agency in Berlin, we can see what are the development of the rates of resistance for certain bacteria which are in focus. If we look to the Staphylococcus aureus, we see that there is a slight downwards trend, that at least in Germany from 22, now in the last years available, only less than 20% of all isolates were resistant. If we look for the vancomycin resistant Enterococcus faecium, we see that we have not a clear downward trend, but the other way around, we observe now 16-70% of all isolates being positive. Same onward trends that we face a higher rate of resistance is due to the Escherichia coli isolates, especially for Klebsiella pneumonia, which are rising from 70% to 10% of all isolates, meanwhile having a resistance. Pseudomonas aeruginosa is due to 6-7% for a threefold resistant, and for the fourfold resistance we are already here with 3%. The clinicians don't have any compound in reserve to deal with these patients suffering from a Pseudomonas aeruginosa resistance. And also very difficult to get rid of is the Acinetobacter baumannii, which has a high resistance in the environment, and once you have this in the hospital, you have really an emergency situation. Altogether, you see for the last decade that the detected MRSA are stable with a less downward trend, that the E. coli and the Klebsiella pneumonia are rising year by year, and also this is true for vancomycin resistant enterococci. So we face an increasing level of resistance. If you look where we can observe the incidence of these infections, then we see that the intensive care units, they are the hotspots of this development. And compared to an ordinary normal ward of patient care, inpatient care in hospitals, we see that we have a more or less twofold incidence with this resistance germs in the intensive care unit setting. And this is very plausible because in this setting we are using devices. We have artificial breathing, we have central venous catheter, we are doing a lot of punctures, and we are applying all kind of medical devices which are able to get through the barrier of the intact skin. Who are the species we are concerned of? If we look to the ICU intensive care units, then it is mainly the Pseudomonas aeruginosa, where we are often at the end of our possibilities to treat, especially then a sepsis, which is derived from a fourfold resistance of these gram-negative bacteria. Then the Echinocybacter baumannii, Klebsiella pneumonia, Enterobacter, and more rarely Stenotrophomonas maltophilia or Escherichia coli. These patients also are imposing an economic burden. There are several economic studies, especially for MRSA, that say per case we have an extra expenditure of between 2,000 and 4,000 euro per case, which the hospital is not compensated for. So we have also an economic interest to have the number of these kind of infections low, because we are subsidizing the treatment of these patients. I have brought with me a couple of slides from my own facility, and this is the Dietrich Bonhoeffer Klinikum in Neubrandenburg. We have about 42,000 inpatients a year, and we cover all medical disciplines besides heart surgery. What you can see here in the green lines are the imported cases of MRSA per year. The other colors are imported infections, or the blue ones are the nosocomial colonizations, and the red ones the nosocomial infections, which happily are going down since a couple of years. What happened between 2011 and 22? I came to that place and took responsibility on hospital hygiene. And since the 1st of January of 2012, we were doing a screening program, which means on each patient's admittance, we are asking with a questionnaire if the patient has a kind of risk factor, which means has he been to hospital in the last year? Has he got antibiotic treatment? Is he living in a long-term care facility? Is he a patient which is on dialysis, and so on and so on? Or has he relative or himself working in the food industry? If only one of these risk factors is positive, he gets a microbiological nose-throat swab, and about 60% of all our patients get a microbiological test on admittance. So we are now detecting those patients, those 90% which come with this situation to the hospital, so we can take measures then if we know about it. If we look how long are these patients staying in the hospital, the average duration of stay is less than 7 days for all patients, regardless of their status. If they were detected as MRSA positive on the day of admission, then the stay is already 11 days. If this is not a colonization but an infection, it is even 2 weeks already. Nosocomial colonization and nosocomial infections are then increasing the duration of stay, and also that has to do then with the probability of complications. This you should not see in detail, but this is the list of departments, and the green bars are those who receive patients with MRSA positive swabs. So this means this is a common feature. All departments have to deal with the situation to serve for MRSA positive patients. They all have to learn what isolation measures are needed. The fatality rate of MRSA positive is more than double the usual one. We have about 5% lethality in these patients. These patients are not dying all of MRSA, but they are dying with MRSA. So it is also an indicator for a very severe outcome. The red bars are the nosocomial transmissions, where we are responsible to look after. And you see these are in the left part of the columns, these are the intensive care units, and this is the surgery department. So this is plausible that it is a higher probability of nosocomial transmissions in these areas of the hospital. If we analyze the age distribution of all our patients and the age distribution of the MRSA cases, we see that we have an overrepresentation of the older patients, namely those over 70 years of age. And if we look to the age-specific MRSA prevalence, and we did this for more than 100,000 of our patients in the last years, we see an increasing prevalence having more than 1% over 60 and ending up by 2.5% of all patients in the age above 80. And older patients are the ones who are increasingly using and needing hospital care. And our demographic pattern is very comparable with those in the Baltic countries, where we have more and more proportion of the population being in these older age groups, having a higher probability of hospitalization. There's also a difference between male and female. Males are worse off compared with females. If we look, this is 0.8% for females and 1.3% for all males. This is not only for the imported cases, but also true for the nosocomial infections. There are speculation out what does that mean about the hygienic standards of older men, or is it a physical difference, or is it a higher probability of getting urine catheterization. These age distribution and the correlation between older age is true for both sexes, and you see that men above 80 years have a 3% prevalence. That is a very good rate for doing screening programs if you have 3% of positive rates to detect. Looking to normal care and intensive care units, you see that the double of the prevalence is in the ICU. Now coming to the other 3- and 4-fold gram-negative bacterial with the multi-resistance, the same pattern for the age distribution applies, which you have seen. And also here you see the age-specific prevalence is already in the magnitude of 1%, 1 additional percent to those 2% of the MMSR, which I showed you for the age group of the above 80s. The proportion which is imported to the hospital and the proportion which is detected only after 2 days in the hospital, which is the classification to be nosocomial, regardless if this was transmitted in the hospital or only too lately discovered, is with a higher proportion for nosocomial. Also for the other multi-resistance bacteria, we have the prevalence 4 times, 5 times higher in the intensive care unit setting compared with the normal wards. What's the distribution by species? And we detect mainly E. coli, then Klebsiella pneumonia, and we have then the Pseudomonas aeruginosa. But when it comes to the 4-fold resistance pattern, then we have a dominance of the Pseudomonas aeruginosa. The rate of being resistant as a percentage of all the isolates, it says that Klebsiella pneumonia with 6% of all isolates already resistant takes the lead, and coli follows, and Pseudomonas aeruginosa is on the 3rd place. What is the source of positive specimens? Mainly it is detected in urine, then in wound, then in the airways, and followed by others. What are the risk factors which have been detected? This is high age, this is being immobile, these are problems with swallowing, problems with incontinence of either the urine tract or the gastrointestinal tract. It is multi-morbidity, chronic diseases. There is a high comorbidity to diabetes mellitus, being under dialysis, and of course decubitus ulcera and chronic wounds, ulcus cruris for instance. These are patient-bound factors. And then we have the external factors like the invasive procedures, the number of devices we apply to the patient. It is the continuous therapy with antibiotics, especially with quinolones and third-generation cephalosporins, which are responsible for triggering the resistance, and the number of hospital stays. That 90% of patients at admittance to hospital present such a resistance situations does not mean that they have not been nosocomially infected on a previous stay. If you calculate if the number of stays in a hospital in this age group would be enough to have enough converters to resistance colonizations, then you come to these decisions. So what are we doing? What can we monitor? We can ask our staff really to be aware of that. And once a patient has one of these conditions which are described, then at the door of his room we have this notice board which says, "Visitor, please report to the nurse's room before entering the room." And you get a pictogram advice that you have either to disinfect your hands, or to wash, or to do both. For instance, if you think of Clostridium difficile, to wear a protective gown, to wear a face mask, and to use gloves. This is ticked then by a cross in the box, so that also our patients, who sometimes come from other countries and not aware about English or German, but also they are then advised how to behave. And for our staff we indicate then, is this an MRCA, is this a threefold or fourfold other bacterial resistance, is this a vancomycin resistance, is this Clostridium, or is this tuberculosis, or is this a norovirus outbreak situation. Thank you for your attention.